Okay. So we start the meeting. Good morning, friends. Welcome back to Saturday Club morning meeting. And today we have one very eminent physician of Baroda, Dr. Parag Rana. He is MD Medicine. He did his internal medicine MD from Baroda Medical College and did his postgraduate diploma in diabetes management from Middlesex University. And he has been attending several conferences by Asia Pacific Diabetes Association and American Diabetes Association. He was awarded my FM award by Divya Bhaskar Media Group. He has participated in several clinical trials which are published in reputed journals. Currently, he is Secretary of Association of Physicians of Vadodara and Joint Secretary, Indian Diabetes and Cardiometabolic Disease Association. And apart from all this, he is a very popular speaker and very eminent physician of Baroda city. He is going to share with us the update on diabetes, a synopsis of ADA conference 2023 attended recently by him. So over to you, Parag bhai. Welcome to Saturday Club. Thank you for accepting our invitation. You have about 40-45 minutes to talk and we'll keep about 10 minutes for discussion. Over to you, Parag bhai.
Thank you so much, Satish, for inviting me to Saturday Club. Saturday Club has always been a nostalgic song because of my close association with Girish. I've been attending Saturday Club quite often. So with Satish Chaka and Girish both, we have been a spectator to the Saturday Club, and in fact, many times I used to wonder that this is something which very few souls have got that ability and courage to continue for so many years, and probably you have continued that torchbearer. So I again congratulate and salute you for the continuing of this entire momentum of academic learning.
Thank you.
My lecture is a short lecture, 20, 25 minutes. We have more time for discussion. Now, this 2023 was at the San Diego Convention Center, and I decided to update a few of things which I thought of worth updating. Not changing. Yeah. So today we are going to discuss four things. One is we are going to discuss about the glycemic excursion minimization. Second, we will be discussing about the SURMOUNT-2 trial. Third, we will be discussing about the lipoprotein insulin resistance score, and we'll discuss something about the TeleWest award lecture. So first, we discuss about the glycemic excursion minimization. This lecture was taken by Daniel Cox. This is a paradigm shift in the management of the type 2 diabetes. Basically, whenever we eat food, it is always an up curve and down curve, we all know. Whenever we eat food, the sugar goes up for the first 45 to 60 minutes, and after sugar goes up, it is after that the insulin comes into picture and the sugar subsequently goes down. So this kind of curve is got an up curve and down curve for any glycemic, basically. Any glycemic you see, it's a normal curve that we have. Now, what happens is we call it a feedback loop. So what happens is that in patients of type 2 diabetes mellitus, the up curve is little more. It goes little for a longer period. If you see the pre-diabetic population, pre-diabetic populations, 1 hour sugar is more than 160. Before they know that they are in diabetes, then 1 hour is more than 160. So it's time for them to be more cautious and more change the lifestyle modifications and everything. So the type 2 dysfunction, when there is insulin resistance and or insufficient insulin to utilize or the store glucose. So what happens is that, as you can see in this slide, the up curve goes up, it lasts for a little longer period, and then it goes down gradually. So that is one of the reasons that diabetics have got this issue of persistent hyperglycemia. So essentially, when we talk of the paradigm shift, what basically means? So if you want to control the blood sugar, there are two important things that come to the mind. You have to diminish the blood glucose rise, that is number one, and you have to hasten the blood glucose recovery. So these two things are very important, because when you talk of the glycemic excursion, when you want the sugars to come down, when you want your glycemia to be under significantly controlled, there are two things which are required. You need to diminish the blood glucose rise by decreasing the routinely carbohydrate consumption which you are taking, carbohydrate consumption, that is number one. Number two, here's how to listen the blood glucose recovery. So there are very simple things they have suggested that after breakfast, after lunch, and after dinner, you can walk for around 2 to 5 minutes. This article was published in September 2022 in the Journal of Sports and Exercise. It very clearly demonstrated that if your patients walk only for 2 to 5 minutes immediately after meals, the response of the blood glucose curve which we saw, which is a significant decrease in the postprandial excursions of the sugar. So when you talk of these excursions, so first of all, what you need to suppose something you have got a very carbohydrate meal, then you will go for 20 minutes. So that's the best way to decrease the blood glucose excursion. And the more the blood glucose goes up, the more effort you try to bring down. The first step is to reduce the carbohydrate content of your food. That is number one. And number two, start walking after your each meal. So as you can see in the slide, the conventional therapeutic options to reduce the weight, adipose fat tissue, reduce the insulin resistance, medications to increase the insulin. All these things essentially.
Parag bhai, sorry to interrupt, but it seems the voice is still not clear. I asked other people also
The
to.
voice is not clear. Okay.
Yeah, so it goes intermittently up and down.
Oh, okay. Let me come near to the screen. Is it better now?
No, your voice goes down. I mean, volume goes down in between. So we hear only broken, kind of speech.
I do not have the. I did not get my headphones also. Okay. Let me.
We can't hear you.
Okay. Can you hear me?
So I think I don't know, but if you remain closer to your device, probably we are able to hear you.
Yeah. So can you? Okay. Is it better now or is it same?
No, it's.
Is the voice better or it is same?
It is almost.
Is the voice better now,
Yes.
or is it?
Yeah, this is very clear now. This is
very clear. Okay, that's fine. So is it clear? Yeah.
Yeah. What did you do? How did it become so clear now?
I came near to my screen, significantly near to my screen.
Okay.
Okay, that's fine. So the convention now, is it clear, right?
Yes.
Yeah. So the conventional treatment options, you have to reduce the weight, you have to medications to increase the insulin production, reduce the insulin resistance, and to promote the glucose excretion. So when you do these things, essentially, what happens is that your sugar would start coming down immediately. So this is the protocol that they have been following in glycemic excursion minimization. No need to go in the details of it, but essentially what it tries to do is that first you try to know what carbohydrate you are taking in your daily diet. One of the very important things that I have found is that suppose you want to know that what is the rise of the sugars, what is the rise of your blood sugar when you take a particular meal. Now, in today's era of continuous glucose monitoring, if you put a Freestyle Libre sensor in your body, you will immediately come to know that I have taken this particular meal and this is the blood glucose rise in my body. So you will try to avoid these kind of meals, because you can without testing with the glucometer, you can actually come to know that these particular meals are causing more rise in the blood sugars for me. So even if you are non-diabetic, you can avoid those kind of high spike sugars, because some people would have fluctuations with a particular amount of carbohydrate load. Some particular patients would have a particular amount of carbohydrate load. So the next trial was on the SURMOUNT-2 trial. Now, the SURMOUNT-2 trial was about the results and the potential role of tirzepatide in treating obesity in type 2 diabetes patients. Now, this basically your therapeutic they discussed about the current therapeutic landscape for treating the type 2 diabetes mellitus and 2 diseases requiring optimal therapy. So, what was the inclusion criteria in these group of patients? So the inclusion criteria was that the patient should be having type 2 diabetes mellitus. They should be more than 18 years old. Their BMI should be more than around 27 milligram per meter square. Their HbA1c should be more than equal to 7 to less than 10. They should be on the stable therapy for type 2 diabetes for more than equal to 3 months alone or any oral agent. So essentially, there should not be any therapy which should reduce the weight in any patient. GLP-1 RA should not be there. The key exclusion criteria in these patients where they should not be having type 1 diabetes, they should not be having prior or planned surgical treatment for obesity, and current or prior treatment with DPP-4 inhibitors, oral GLP-1 RA, or an injectable therapy for type 2 diabetes mellitus, and there should not be any use of medications intended to promote the weight loss. So this trial essentially was started in the This trial was essentially initiated in March 2021 and conducted almost entirely in the setting of the COVID-19 pandemic. The overall completion rate was high, more than 90%. So in this trial, they included some 938 patients, 315 were placebo. There had 10 patients, 312 patients received 10 milligram of tirzepatide, and 311 patients received 15 milligram of tirzepatide. Now, after this trial, it very clearly showed that when the tirzepatide 15 milligram was given, more than 80% of the patients achieved American Diabetic Association's recommended target of less than 7%. More than 75% achieved American Association of Clinical Endocrinologists recommended target of around less than or equal to 6.5%. And more than 45% achieved normoglycemia. Now, this was a remarkable breakthrough study because this kind of weight loss had never been achieved. So tirzepatide 10 milligram and 15 milligram demonstrated superior and clinically meaningful body weight reduction compared to placebo. Up to 86.4% of the participants achieved more than or equal to 5% weight reduction, with up to 34% of the participants achieving more than 20% of the weight reduction. Up to 17.2% of the participants achieved the exploratory endpoint of more than or equal to 25% weight reduction. All the primary and the key secondary objectives were met for both estimated analysis. Your HbA1c went down, your glucose went down, your systolic blood pressure went down, your lipid parameters went down, your waist circumference went down. So everything was positive. So that was the beauty, that when you decrease the weight, your diabetes would respond wonderfully. That is why the recent approach of diabetes has been what we call it as an upstream or downstream approach. Initially, we used to have a glucocentric approach. We used to reduce the blood sugars and then we used to see how the complications they do reduce or not. But in the upstream approach, you target the obesity, you target the weight, you target the sugar simultaneously. So if you have agents that they target the sugars and they target the weight, you will have significant reduction in hypertension, you have significant reduction in patients having NASH, you have significant reduction in patients having osteoarthritis, you have significant reduction in patients having sleep apnea because of the obesity. So all these factors, apart from the reduction in the cardiovascular mortality, morbidity, and the CD strokes, all these benefits you can achieve when you have upstream approach in treating the diabetes. So at the first instance, when you start medications, if a patient is obese, then if your patient is fitting into the criteria of starting these GLP-1 RA medications, you are going to have wonderful long-term benefits in these patients of diabetes mellitus. Timothy presented this wonderful lecture on this tirzepatide. Now, if we see the weight loss therapy in type 2 diabetes mellitus, the lifestyle would reduce to around 2 to 7%. The lab band would reduce to around 10 to 20%, and the gastric bypass or sleeve would reduce to around 25 to 40%. So second generation medications would reduce up to 22% without diabetes, and with diabetes it will reduce to around 50 to 20%. So that's a wonderful progress as far as the obesity weight loss therapies are concerned. Now, see, we first came with the concept of monoagonist, which basically means that you have a GLP-1 agonist. Then there was somebody called Matthew Shaw. In 2005, he was actually a researcher. He was a clinician. He decided to go into research, and he decided that why cannot be GLP-1 agonism and the glucagon agonism can be developed to reduce the further sugar and weight issue. It was at that time that we very clearly believed that there is a glucagon suppression that is helping us in reducing the sugars and helping us reaping all the glycemic benefits. But this man went against the tide and decided to make a significant research on the glucagon agonism and GLP-1 agonism. And in this pursuit, he developed a molecule which is known as retatrutide. Now, this molecule is a triple agonist. It is a GLP-1 receptor agonist, GLP-1 agonist,
glucagon insulin polypeptide, and the glucagon receptor agonist, three combined together. And this molecule is said to change the entire diabetes landscape in the coming times of next 2 to 3 years. The trials are much more practical and much more, the results are wonderful. And it is said that it can reduce weight about 25 to 30%. Basically, if it actually achieves that target, in next few years, bariatric surgery would be a thing of the past. So this was the man, Matthew Shaw, whom I met there. And in fact, he was delivered a Bentic Best lecture. This man delivered the lecture so wonderfully that I had no words to praise him, because he went against the tide and discovered, and in fact, it came into clinical practice, which was the most important part. Even when you talk of the American Diabetic Association and European Association of Study of Diabetes consensus, it very clearly said that when you want an approach where you want to reduce the glucose to very high and you want to reduce the weight also, in that case, you can use a molecule called dulaglutide in high dose, semaglutide, tirzepatide, and insulin. So when we talk of reducing the weight, when we talk of reducing the sugars, then there are only two molecules, semaglutide and tirzepatide. When you're not much concerned about the weight, when you want just to reduce the sugars, then our insulin would also come into picture, and our dulaglutide high dose would come into picture. So essentially, these GLP-1 agonists have been a wonderful molecules for helping us out in management of diabetes on day-to-day basis. So initially, we had a semaglutide, then we have a tirzepatide, and the next big wave, which I talked of, the triple agonist is coming next 2 to 3 years, which is probably going to change the landscape, the way we treat our patients of diabetes mellitus. Another lecture was by Samia Mora on the more specific lipoprotein measurements. Are they a waste of time and money, or do they personalize care? Normally, in our day-to-day practice, we measure apart from the routine lipid parameters, we measure the non-HDL cholesterol, we measure the apoprotein B, we measure the lipoprotein A. We do not measure the LDL particle number, we do not measure the lipoprotein insulin resistance. Now, why are they important? Because when they measured the lipoprotein insulin resistance, they noted that people who are non-diabetic in the women's health study of 25,925 patients, this lipoprotein insulin resistance score, which is normally up to 0 to 45, it is more than 45, it predicted the type 2 diabetes risk. Not only that, but it was the strongest biomarker predictor of premature coronary artery disease in women. Now, this lipoprotein insulin resistance score basically measures the VLDL particle size, the large VLDL concentration, the HDL particle size, the large HDL particle size concentration, the LDL particle size, and the small LDL concentration. So essentially, when you sum up all these particle numbers, you have a higher future type 2 risk, future type 2 diabetes risk stratification, and which is above and beyond HbA1c or HDL triglyceride and your BMI. Now, this LDL particles essentially is measured in India. Dr. Lal's Path Lab, they do measure this LDL particle size. This is measured with the help of electrophoresis. Since last couple of months, they do not have the kit for this. Otherwise, they used to measure this LDL particle. And this LDL particle size can actually tell us that whether these patients are, how much significantly they are at risk. Now, why it is important is that this patient who is having LDL of 130, see here you have two patients. Both the patients having LDL of 130. But if your patient is having fewer LDL particles, he or she is at lower risk. And if your patient is having more LDL particles, and then he is at significant risk. So if your non-HDL cholesterol is more, if your LDL particle normal value is up to 1028 millimoles per liter, so if your LDL particle is more than 1000, if your LDL particle is more than a normal value of more than 1035, of your ApoB is also more, your non-HDL is more, then you are at significant higher risk of an coronary artery disease. Now, in absence of availability of the LDL particle routinely, we can measure each VLDL, LDL, IDL, and LPA carry one apoprotein B. So apoprotein B is the total number of these atherogenic particles. More than 90% of this apoprotein B is in the LDL particles, Hence, apoprotein B is more or less equivalent to your LDL particle number. If somebody wants to measure, no, I want to have a specific measure. In that case, the LDL cholesterol, which is available in the millimoles per liter per unit, is obtained by multiply the milligram per deciliter mass constant. You have to convert your milligram per deciliter to millimoles per liter with the help of multiplication factor of 0.0259, and then you divide with the LDL particle number, which you get in always in nanomoles per liter. And this ratio which I talked with LDL, this ratio which I talked is helpful in these patients to summarize. Next was a very interesting lecture by Diabetes in South Asians, uncovering novel risk factors with longitudinal epidemiological data. This lecture was the Kelly Best Award lecture. This was given by Alka Kanaya, who was professor of medicine in University of California, San Francisco. This in US, there was a study going on, which was known as MISA, which is called as Multi-Ethnic Study of Atherosclerosis. In this study, they had included white Americans, Black Americans, Hispanic Americans, and Chinese Americans. So a group of researchers from this from the UCFA, they thought that why cannot have we study for the people of South Asian origin, which is around 29 countries altogether. So they decided to put forward this mediators of atherosclerosis in South Asia living in America. They call this as MASALA. Mediators of atherosclerosis in South Asia living in America. 4 or 5 times the NIS rejected their grant, but ultimately they could succeed of getting the grant. So what they did was, their first purpose was to create the subtypes of diabetes. So when they talked about the MISA and MASALA subtypes, there were some 1,293 participants with type 2 diabetes mellitus. There were 240 white, 387 black, 324 Hispanic, 125 Chinese, 217 South Asian. 5 variables they decided to cluster, they decided to use as parameters to cluster and divide the diabetic patients which are already existing. Age, body mass index, HbA1c, HOMA-IR, and HOMA-B. Now they compared the distribution of these subtypes and the future diabetes complications of the kidney and the coronary artery calcium. Now when they classified this, they decided they could manage, they could see that there are 5 distinct subtypes of diabetes. Cluster 1 was older age of onset, which was around 44%. Cluster 2 was severe hyperglycemia, which was 26%. Cluster 3 was severe obesity, which was 20%. Cluster 4 was insulin use, which was 9%. Cluster 5 was younger age of onset. Now, what they did was they dissected the data further by the subtypes, by race or ethnic group. Now, as you can see in this slide, the last slide is of the South Asian group. Now, in this, the striking finding they found was that the 38% of the patients of the South Asian group presented with severe hyperglycemia. So their beta cells had already been destroyed them when they knew that they are having diabetes. 29% were old age group and 24% were having severe obesity. Now, this is in contrast with the Chinese group, where the 67% were having the old age group, and in the white people, the 56% were having older age. So there was a striking difference in this analysis, which said that the South Asians, when they present, they already have a significant beta cell dysfunction. So the longitudinal outcomes by the subtype. Why does subtype matter? Because as you can see in this slide, the 38% severe hyperglycemia puts them risk at significant coronary atherosclerosis and cardiac events. So you need to consider newer agents like SGLT2 inhibitor or GLP-1RA to lower the CVD risk. You need to have an older age at onset. When there is older age at onset, it will be least aggressive. Don't worry much about it. You will need much less medications, and you need a less tight control. When there is severe obesity, there is no higher CKD or atherosclerosis. And in that case, basically, you will concentrate more on the weight loss, metformin, and you will take care of the TZDs. When they again they subdivided, they dissected further. As you can see, we all know that the Asians, the value of the BMI is less than 23. Over 23 to 27.4 is your overweight, and more than 27.5 is your obese. Now, in the normal weight individuals, as you can see, almost 27% of the Southeast Asians, which is orange in color, the 27% of the Southeast Asians were already diabetic. So if you consider like that, then so many of the normal weight patients in our setup would be having diabetes, and we are probably missing them. So we need to screen them more often. So essentially, after the dissection of the data, they found that the South Asian BMI of 19.6 is more or less equal to white BMI of 25. That was quite striking epidemiological finding. Epidemiological studies are the torchbearers and in fact, it is the basis of our medical science. And in fact, they have given a lot of insights for any diseases. Another thing, that we have hidden fat stores, which essentially include the visceral adipose tissue, the fatty liver, the intramuscular fat, the pericardial fat, the perivascular fat, the renal sinus fat, and the myocardial fat. Now, the problem that we have the South Asians is that we store fat at the wrong places. We South Asians store in fat in the liver. We South Asians store fat in the visceral fat. That is one of the reasons that we have significant more incidence of diabetes mellitus, and we have more diabetics compared to any other people. So you can see in the slide that if your visceral fat area is more, if you are having more fatty liver, then the normoglycemic progression to prediabetes or diabetes or prediabetes to diabetes is significantly high when you have these parameters which are sick. So you can prevent this. The entire concept is that if you detect these patients earlier, the n number of trials have shown that it is possible and easier to for patients to prevent from prediabetes to diabetes rather than once they are diabetes. It's a little difficult task for patients also. Another thing, they also studied about the dietary patterns of these patients. There are some 164 items basically of the questionnaire. They noted that the patients who were having more animal protein like alcohol, coffee, eggs, fish, pasta, pizza, pottery, red meat, refined grains, vegetable oil, all these things, they had increased total LDL cholesterol, they had increased weight and waist, and they had increased liver fat. People who were taking more fried snacks, sweets, high-fat dairy, like your added fat, butter, ghee, fried snacks, sugar-sweetened beverages, legumes, potatoes, refined grains, rice, snacks, sweets, it decreases the HDL cholesterol and increases the HOMA iron. And patients who were taking more fruits, more vegetables, nuts, legumes, they had decreased incidence of hypertension and decreased incidence of metabolic syndrome. Now, in that particular plant-based diet also, they divided on the basis of the plant. They divided on the basis of the plant diet index and the it was a healthy PDI and the unhealthy PDI. So patients who had whole grain, they were healthy. Patients who had less healthy was refined grains. Patients who had taken fresh fruit was better. Fruit juices were less healthy. Patients who were taking vegetables was good. Potatoes were obviously less healthy. Patients who were having herb spice was good, more healthy. Deep fried snacks was not good. Nuts were good. Coconuts was less healthy. Legumes were good. Sweet cereals were not good. Tea and coffee were good, and sugar-sweetened beverages were not good. So essentially, to summarize, the South Asians have a higher type 2 diabetes prevalence, which varies by subgroup. There is more beta cell dysfunction than previously recognized, and more ectopic fat and lower muscle mass. There is rapid transition from the pre-diabetes to diabetes. There are many modifiable risk factors. It leverages the social networks for the lifestyle change. The basic thing is that you need to change your lifestyle very rigidly. And at 180 degrees, if you are having pre-diabetes. Risk factors vary dramatically among Asian American groups, and longitudinal data would provide the more insights fundamentally. Thank you.
Thank you, Parag Bhai. Just a minute. Are you able to hear?
Yes, yes, I'm able to hear. Yes, Satish bhai, I'm able to hear.
Okay. Thank you very much for covering these updates in a very comprehensive manner. So
Thank
now
you.
we are open for discussion, comments.
Yes,
All
sure.
participants can participate.
Sure, please.
There are some physicians.
Yes.
Bhai che, Chetan bhai che. So comments are invited.
Please.
So if there are no questions, at least I have a question. I mean, anything was
Yes.
discussed about diabetes type 1, children, adolescents?
Yeah, children, children type 1 diabetes, it was discussed as type 1 diabetes. Essentially, we all now know that the key to the type 1 diabetes mellitus is the insulin pump actually. So if you need to patients that put on insulin pump, that is number one. And another, they approved on November 17 a molecule called teplizumab, which had the significant role in changing the course of the type 1 diabetes. So from the stage 1 to further, they will not progress, in type 1 diabetes. So that was one thing which was there. And in fact, in the developed countries, there is very high incidence of type 1 diabetes in few of the European countries. When you see the data of their data and our data, because the only way to help these patients is insulin pump, because there is no other way you can actually help these patients.
Right.
So if you put on insulin patient, come on to these patients, you can actually significantly prolong their life and the quality of life and everything. It's a remarkable change actually. Cost is an issue in our country, is a different thing, but otherwise that is the best way to help out these type 1 diabetes. They're significantly volatile and labile. Sugars would go haywire. You must have seen our practice that it's very difficult to manage type 1 diabetics.
Yes, but
Very
now
good,
things are improving with continuous monitoring as well as insulin.
Yeah.
Things are much better.
And another thing is we give them more pricks. There is another way to help out. So that is what will also help in.
So Kiran bhai has commented, good informative talk.
Thank you, Kiran.
Parag, of late we have been doing a lot of CGM.
Yeah,
and
absolutely.
my experience is that we see, the patient finds a lot of excursion in their blood sugar level in spite of this thing. And the patients get more panicky and they are more.
Actually, Chetan bhai, the reason is that what we are having is a freestyle Libre 1. So this is a very old, the MARD, the mean absolute relative difference of this freestyle which we are using is actually not good, honestly. So if you want to use in our country, see what it does is our CGM that we are using, it causes more hypoglycemia which are not required, or they are not so much corrective. So they don't need that they don't need correction. So it documents more hypoglycemia which are not to be the MARD, because of the MARD they report 50 but actually it's 70, 80, something like that. So the MARD is one thing which in our country, if you want to use the Medtronic CGM is the best CGM, because that I myself have put in my body. I'm a non-diabetic, but I put in my body too. Then I put both the sensors, CGM, this freestyle, as well as both for 14 days I have put, and I have compared with the glucometer. I have concluded that the Medtronic CGM data is much more. Even the MARD is much better. Even if the data, the MARD is much better of this compared to the freestyle Libre that we are using. Only problem is that it is cheaper. This Medtronic CGM is costing 50,000 bucks, which we cannot use. And the freestyle Libre 3 is very good, but they have not brought this Libre 3 in our country. Their MARD is around 8.1 or so. So that is the reason that people go in panic, and this is one of the reasons. So that is why these limitations are there of CGM in our country, but there is no other way out, at least for now.
Yeah, that's right. Because I had the same feeling that the fluctuations are so much that in fact they are not acceptable.
So that is what I generally do. Is when I give them, I tell them that you don't interpret, leave it up to me to interpret. So don't go into panic mode, because so we need to have, because now we have done so much that we have our own judgment of this. So, okay, this is how we go forward. How much importance to be given to these kind of sugar data here. So that is one. That's how I do it, because otherwise, in the initial when we started to do it, we ourselves were also confused. And last year when I went to EDF, they introduced freestyle laboratory. So the gentleman, the German professor was introducing. I told him that this is the issue that we are facing. He said that you are absolutely right. This is the problem. So he also told the same thing. We need to have our own judgments, and we need to tell patient that you leave it, interpretation, leave it up to us. We'll manage. But that's the problem. But that has been rectified to a great extent in the new generation CGMs, I believe.
But then what is your take? Because we are talking about TIR, TAR, TBR, but when the Libre 1 is only available, would you like to recommend it to the patient? Because nowadays, with this Google and everything, patients themselves come and tell us that, sir, why are you not recommending CGM?
I do recommend it. I do recommend it, but I tell them to take with a pinch of salt, and I tell them that only advantage is that of this kind of thing is that it would tell us in which part of the day you need to concentrate for the glycemia management. So part of you may not go for the values, but we'll come to know that, okay, this part of the values. And then I always, when the problematic part of the day, I ask them to correlate with the help of glucometer. So that helps us a lot in managing. Suppose the patient is having, say he's having 4 p.m. issues, or he's having post-lunch issues, or 3 a.m. issues. Then in that case, I ask them to correlate with the glucometer. Plus minus 1 hour, I ask them to take the glucometer readings, and then that's how I manage it. That's how we have to do it. I could not find any better way to, because whatever we have is this only. So that's the problem.
Wait, Dr. Parag, there is a concept called chrononutrition.
I couldn't get it. Please.
Chrononutrition.
CHORO, chrono?
Chrono, yes.
Yes. That's right. Absolutely. Yes, there is, in fact, a Society of Chrono Medicine also. So that's why I was telling you.
So
yes.
Does intermittent fasting or the Jain religion habit of those who follow to take meals before 6 p.m. help in glucose control?
Yes, definitely. Because what happens is that this is going to help. Whatever whether we will easy, because one thing is very clear that it is for everyone. For diabetics, obviously, it's going to help. But even for normal individuals also, if once in a week, if they do D2D, even we all, if we can manage for D2D is dinner to dinner. Once in a week, we take dinner at Sunday evening, and then we take another dinner at Monday night. That's also going to help. So essentially, fasting in any form is going to help. Intermittent fasting is going to help very clearly. But people who they need to manage their nutrients and everything so well. And earlier you take dinner, it's obviously going to, your liver is going to thank you because of the glycogenolysis issues. There is no question about it. It's going to help. There is no much arguments or no very. It's a very clear cut data.
Against that, eating frequent meals is required for some.
No,
because some people say that their liver cannot store so much of glycogen to meet the hunger. Hunger is a new focus of study.
So essentially, each and every diabetic would be a different ball game, frankly. So it may not be possible or feasible. We always tell patients eat 5 times, but that may not be the correct approach, I believe so. Because somebody is comfortable for 3 times a meal, that's fine. You can manage your, if that patient is sugars are managing well, there's no point of forcing him to take 5 times a meal. Take 5 times, there's no point of, there's no logic in that. If he's not able to, if his sugars is not getting control, if his insulin is and glycogen release both is in that manner, it's a different story. Otherwise, that's absolutely fine. So we need to tailor-made each and every patient when we see them. So that's how diabetes is.
Maybe the hepatic steatosis affects the glycogen storage, which is less in these people and makes them eat more frequently.
Perfect. That's right. Absolutely.
So any more comments or questions? Okay. So if there are no questions and comments, I think we close the meeting here. Thank you, Parag Bhai, once again.
Thank you so much, Satish, for inviting me. Thank you.
Thank you. So thank you all. We meet next Saturday morning again. Thank you.